Welcome to ARI 2024, Alicante Refractiva Internacional. This is a session of clinical cases with a special interest, and it's a pleasure to introduce you Dr. Nuno Moura from IMO Grupo Miranza, Barcelona, and he's going to talk about topical Losartan as an adjunctive treatment for postadenoviral pneumolar keratitis. Nuno, we hear you.
Thank you, Dr. Gessa. Welcome to RA 2024. Good morning. I'm here to present you a case of topical Losartan use as a potential adjunctive treatment for postadenoviral pneumolar keratitis. So this was a 22-year-old patient who was referred to our center for decreased visual acuity and photophobia due to refractory corneal subepithelial infiltrates in both eyes. Past ophthalmic history is relevant for epidemic keratoconjunctivitis due to adenovirus in June 2024, and which left some corneal subepithelial infiltrates which were refractory to topical dexamethasone drops in the posology of 2 times per day. So these are the clinical photographs. You can see on the slit lamp image severe, large, confluent, coalescent subepithelial infiltrates, more severe in the left eye, and the best corrected visual acuity was 20/60 in the right eye and 20/80 in the left eye. You can see here in the corneal densitometry by Scheimpflug camera imaging, you can see here that the anterior layer of the cornea has increased corneal densitometry values, and you can see on the right boxes that the anterior central densitometry values were 79 and 76, which are quite high. So the decision was to increase the frequency of topical corticosteroids to 4 times per day and to start the patient on topical calcineurin inhibitors. The decision was to use tacrolimus 0.3% eye drops 1 time per day. And we discussed the possibility with the patient to start him on off-label topical Losartan drops in the frequency of 6 times per day, which the patient accepted. And so at 5 weeks follow-up, these are the slit lamp images. You can see that best corrected visual acuity improved to 20/20 in both eyes. The patient was no longer photophobic. This was a very symptomatic patient. He was a nighttime driver, a delivery boy who worked at night. So he was actually on sick leave because of low visual acuity and significant visual symptoms. And the patient was actually wishing to return to work because of the improvement in symptoms. And you can see on the slit lamp imaging a significantly improvement in the corneal infiltrates. And you can see here on the pentacam densitometry scans, the lower image, the smaller images are the pre-treatment densitometry at presentation. And you can see here on the follow-up scan that the anterior layer densitometry, especially in the center, in the central annulus, really improved to 48, which is a significant improvement in corneal light backscatter. So this is a case we have revised the treatment. We are now tapering the patient's steroids slowly whilst keeping him on some topical immune suppression with tacrolimus, and the decision was to maintain topical Losartan for approximately 3 months. I brought this case to you to raise the issue of that we can consider Losartan as a drug for these cases. So Losartan is a type 1 angiotensin II receptor inhibitor. Its use is usually systemic per orally, and it's approved for the treatment of systemic arterial hypertension, left ventricular hypertrophy, and diabetic nephropathy. The relevant pathophysiology mechanism in Losartan at present is that the angiotensin pathway leads to activation of transforming growth factor beta-1, which is a significant molecule in the signaling for myofibroblast differentiation and activation. So upon expression of TGF-beta-1, myofibroblasts proliferate and they secrete both myosin, which has contractile properties, and also a lot of extracellular matrix proteins, which leads to fibrosis and scarring. And nowadays, we also know that this is also a fundamental molecule at play in the keratinocyte activation, myofibroblast differentiation, and corneal wound healing. And this has been demonstrating both in anterior stroma in vitro and in vivo models, as well as in the posterior stroma and the Descemet's membrane, as you can see here in these images, where after a model of wound of corneal anterior stromal wound, there's a proliferation of TGF-beta1 and also the molecules in the downstream signaling that leads to fibrosis in the subepithelial stroma. You can see here in these images that representative. So when there is an injury to the transition zone between the epithelium and the anterior stroma, if the basement membrane regenerates adequately, there ceases to be exposure to epithelial TGF-beta1, and there's a normal response to corneal injury. Whereas if the basement membrane is injured and continuously harmed, as can happen in viral replication case after adenoviral infection, TGF-beta expression in the anterior stroma leads to abnormal myofibroblast proliferation and fibrotic injury. So we propose that Losartan can be used for adjunctive treatment in these cases. Losartan has been used off-label in several abnormal fibrotic or scarring processes in the cornea. We have performed a systematic review of the literature. We last conducted it in June, where we have identified 4 case reports in human already in use, and in all cases there was significant improvement in best corrective visual acuity, and in 2 of them improved the corneal densitometry values, and it has been proposed for post-refractive surgery haze, for cross-linking haze, and for post-infectious scarring. So we propose that in cases where the fibrosis or subepithelial lesions are due to inflammatory etiologies, we can use Losartan as an adjunctive treatment to topical immune suppression to reduce the density of the infiltrates and to improve the corneal light backscatter. So I invite you to join us. I'm in the UCornea board, and I invite you to join us in the 16th edition of the Congress, which will take place in Prague in May 2025. Thank you for your time, and we are open to discussion.
Thank you very much, Dr. Moura. Losartan has been like a revolution, don't you think so? And as you have said, not only in the postadenoviral keratitis, but also in any haze or fibrotic process on stroma. Maybe the question is for how long do we have to use it to avoid recurrences in these cases?
So thank you for your question. The rationale behind Losartan use is to decrease the expression of TGF-beta1 in that epithelium to stroma transition. So I would tend to suggest that we use Losartan as long as we believe there's an injured epithelial basement membrane that acts as a barrier to the dissemination of TGF-beta to the anterior stroma. So at present, I've been prescribing Losartan to a lot of patients with postadenoviral infiltrates. I'm finding more cases where corneal densitometry values really decrease. Even if the number of infiltrates is relatively the same, the density is severely reduced. And at present, I'm suggesting patients to do it at least for 3 months. Obviously, this has an immune etiology, so I think that if there's reactivations upon decreasing topical immune suppression, and there's a reactivation, you can always go back to topical Losartan. But at present, I'm recommending 3 months of therapy.
Okay, thank you very much. Very beautiful cases and the revision. And thank you for joining us to ARI 2024. Thank you very much.
Thank you, Maria.